Good morning. Honorable Moderator, Chairperson, and dear participants. My talk will be the IVUS guided enlightenment PCI. This is one of the cases that I have done recently, that non-STMI with acuity LVF in proportional ejection fraction of 50%. And this is the EKG changes, you can see that. And patient having a prostatic cancer and also severe renal failure, and it is a patient having a COVID pneumonia, and patient admitted to us with all these complications. You can see that RCS, proximal RCS title disease, and the LED is also diseased. Diagonal is a big size vessel, it is also diseased, and LED in the mid part is tight, and the distal left main seems to be borderline disease. So with this case, definitely CABG is not an option of this case, and so many comorbidity and acute situation. So we are planning to do the angioplasty, but problem is that patient having renal failure and COVID pneumonia. It does two things. So dye is an important factor for this. So we use just not zero contrast, but minimum contrast we use it. We do the RCA first. Then we have done the DFR in the left main, because left main was borderline disease. If it is borderline, then if it is not significant, then we can fix up the mid of the LED and the diagonal, that's fine. But it is significant, then we have proceed on and diagonal first, and then 1:10 from the distal LED to the proximal LED, and then we have done the IVUS finally. Then and IVUS result was left main is 13 point. That is, it is an acceptable, and the mid LED is also 6.4. This is also acceptable. So this is the result, and this is the angiographic view. And this is the angiogram, this is the EKG after doing the coronary angioplasty. So now let us see the basic reason for use the IVUS. So pre-PCI, lesion assessment, lesion length assessment, stent sizing and calcification. These are the important features that you can do by IVUS. Post-PCI, stent expansion, stent apposition, is dissection, tissue prolapse, and detect residual disease. These are the things we can detect it by using the IVUS during the procedure. But what is the data that we have to use the IVUS during these complex cases? This is one of the slides which shows that the definite and probable and stents cardiac death is significantly lower if we use the IVUS, and definite probable stent thrombosis is also less if we use the IVUS. This is Mehran, Journal of American College of Cardiology, and myocardial infarction also less if we use the IVUS. You can argue that this is a registry. Where is the RCT data? We can see that the IVUS expel trial shows that the primary point is significantly lower when you use the IVUS than angiographic guidance. And this is that is only one study. You can say that what is the meta-analysis. This is the meta-analysis of the 8 randomized trial of the IVUS versus angiographic guidance. You can see that most of the trial in favor doing the IVUS than angiographic guidance during the PCI implantations. You can say that's just one meta-analysis, and this is the 5 meta-analysis. It is also favor that IVUS is better, MASH is significantly reduced and death is also less if you can do the IVUS uses. And this is the meta-analysis of the 20 DS studies. You can see that the favor IVUS, favor non-IVUS. You can see that when you use the IVUS, it is favor that the IVUS is better outcome, then MASH is better than in comparison favors of non-IVUS. Those are the simple lesion. You can say that what is the complex lesion? This is meta-analysis on the complex lesion. These are the trial, all the trial. It is very difficult to finish by giving the name all trials. You can see that most of the trial in favor that the IVUS guidance even in complex lesions. So benefit of the IVUS, not just TLR. This is the American Journal of American Heart Association 2020. that is cardiovascular death is significantly less, that is 37% relative reduction if we use the IVUS. And 29% relative reduction of myocardial infarction. That indicate that IVUS not only helpful for preventing TLR, but also reducing the cardiovascular death and also myocardial infarction. So IVUS is very useful, especially in left main disease. And if we see the histology pathological left main, we can see that this is the carina, this is the lateral wall, most of the plaque in the lateral wall, and most of the time carina is not significantly plaque in the most of the time. And so that's why everyone says that IVUS is essential for left main PCI. And I will show you one of the case report that is presented by the Gary Mins, that this case was done CABG based on the angiogram, and there is a tight, seems to be tight ostial left main disease. And this patient graft was closed, repeated or twice or 3 times. But when we do the IVUS, that shows that the ostium of the left main is not significantly diseased. That is the reason why the graft is closes. So IVUS is very important to assess especially in the left main disease. IVUS is properly introduced, and in the IVUS, we can optimize the stent expansion, and especially after two stent strategy, we can see that the proximal 8 millimeter, and the distal left main is 7, LAD is 6 and 5. This has to be if the outcome to stent strategy, and if the minimum lumen area is 8 or 7 in the left main and 6 or 5 in the LAD and LCX, then the instant ISR will be less, and then it is the under expansion. If there is under expansion, then the significantly increase of the ISR, and complete expansion is only 5%. So this indicates that with angiogram, you cannot predict that which patient will go for significantly increased rate of the ISR if you don't do the IVUS. And this is a predictor of stenosis in ostial LCX with both LAD and LCX IVUS evaluation. Post LCX minimum area, if it is less than significant, stenosis rates much higher than if the MLD is more than 4 millimeter in LCX ostium. This is 2009. And this is the main compare history. This is the PER who demonstrate that IVUS reduced a significantly reduced cumulative mortality if we use the IVUS than angiogram. And IVUS is not recommended for use for functional assessment of the non-left main, but in left main you can do the functional assessment by minimum lumen area. And what is the recommendation that we have? Current guideline for use of the IVUS, ESC guideline shows that the 2A, the IVUS to assess the severity and optimize the treatment of the unprotected left main. So this is the recommendation, class 2A. But AHA and ACC guideline, class 2A, level of the base, and IVUS is reasonable for the assessment of angiographic indeterminate left main disease. So if we do the significant of the disease, we can use the IVUS also to either you will do the PCI or not. Definitely you can do the FFR that I have shown in my case, or IFR or DFR, and class 2B, IVUS may be considered for guidance of the stent implantation, particularly in the case of left main coronary stenting. So in the recommendation says that, ESC says that class 2A, but SCC and AHS says that class 2B in left main disease for IVUS. So recommendation still is not in class 1, but we have to do it. So on conclusion, ladies and gentlemen, we can say that stenting of the unprotected left main stenosis can be performed with a good result. Patient selection is crucial and must be based on the medical surgical consultation. We have to be consult with the surgeon and also the patient party, and also the ethics of information is also important. We should not be biased. Stenting of the distal enlargement can be achieved without a major technical difficulties with a good immediate long-term result. Stenting of the distal enlargement is a true challenging. For the unport enlargement, single stent stents are still preferred and should yield acceptable result for the 80% of the cases. IVUS guidance should be considered and may improve the clinical outcome. And IVUS provides a superior information regarding the necessity for the adjuvant lesion preparation. That is very important. You cannot depend on the angiogram. Optimize the device sizing to achieve the largest minimum stent area, the strongest predictor of the future events that you can only be performed by the IVUS. Appropriate stent length to cover the interlesion or avoid a geographical mess. That is also important. And stent under expansion or residual disease in the stent is requiring the further treatment. And acute complication, including the stent is dissection, hematoma, stent deformation. In the enlargement, the stent deformation is more than other site. Stent deformation. The benefit of the IVUS guidance on clinical outcome are the most pronounced when treating in high-risk lesion or patient like Mohamed Jaman case. Thank you for questioning. Though it is difficult to cross the LED. Thank you very much.